Hi, good afternoon. My name is Patricia Alvarez. Today I'll be discussing the diagnosis and management of osteomyelitis. So, uh, everything that I'm going to be discussing today is coming from the Science Direct article and NTVI article that I'm going to be linking at the end. So, for an overview, osteomyelitis is a severe progressive infection of the bone. It can present as either acute or chronic, depending on the underlying cause and duration of the infection. Acute osteomyelitis is more common in children and typically results from hematogenous spread, meaning the infection travels through the bloodstream to the bone. Chronic osteo, on the other hand, is often related to trauma, surgery, or the presence of a foreign body. The most frequent causative organism is Staph aureus, even though in chronic cases, it could be bacteria like Pseudomonas. Um, Patients with compromised vascular supply or underlying conditions like diabetes, which we see a lot, if they're left untreated, the infection can cause bone necrosis, abscess formation, and in severe cases, it can lead to amputation. So to look into the pathophysiology, the infection can spread to the bone via two primary sources. It can be contiguous spread or hematogenous. So there are also different types of different classifications: acute, subacute, and chronic. So for a clinical presentation, usually the patient with acute osteomyelitis will present with pain, swelling, and fever, often accompanied by redness, warmth around the affected area. Chronic cases, however, can present with more subtle symptoms like non-healing wounds and ulcers, or even like a sinus tract formation as the body tries to wall off that infection. And in brown patients, this can present differently because you might not be able to see the swelling or the redness on the skin. So kind of exciting. I recently encountered a case that highlights some of these complexities. Just this past Friday, actually at the clinic, a patient presented with a complaint about this right second toenail. He mentioned that about a week ago, a piece of his toe came off. He said he just bandaged it and it wasn't really healing. The patient had a history of showering at a homeless shelter about a year ago, but he recently secured housing and was now taking better care of himself. So when I'm asking him if he has any numbness or tingling on the toe, he pretty much denies it, and I realized that he doesn't feel a lot on that toe. When I ask him if he's diabetic, he's unsure if he's diabetic. He denies pain. And actually, this patient had a significant history of multiple falls leading to Charcot on his left foot. The patient didn't mention his foot as a chief complaint, that left foot. So for the first time ever in about a year and a half, he had something on his right foot. When I examined the toe, the wound had clear signs of Pseudomonas infection. It had like that green tinge to it, which you can see here. And these are my shoes. So this led me to consider the possibility of like a long-term infection, even though he said that he was already housed and for about more than a year now. So I suspect osteomyelitis. I spoke to the attending, I ordered an x-ray, which as one of my articles states is typically the first imaging method for diagnosing osteomyelitis. So here's his x-ray. Right here, second toe, it's clear. So usually an x-ray only reveals changes after 10 to 14 days of infection. In chronic cases, they may show features like sequestra, which is that dead bone fragment, and involucrum, which is the new bone growth around the dead bone. But x-rays usually lack sensitivity for early detection. This patient's x-ray confirmed what we thought could be osteomyelitis. And when I asked the patient, how long ago have you had, like when did you see that toe fall off, which was his initial complaint? And he said, And the patient said, well, it was only about a week ago. So when we go, when I see the wounds and I see that it's so bad, we realize we have to take an x-ray. But normally, if it's only been a week of the infection, it wouldn't look that bad on x-ray. So, I mean, given his poor compliance and unawareness of potential diabetes, he already has neuropathy. We decided the best initial course of action was to send him home with ciprofloxacin and schedule a follow-up in about 10 days. Amputation may be inevitable for this patient, but his social situation complicates this matter, making long-term management a significant challenge. So here's a really good chart from Science Direct, the article that I am linking below. So the sequestra are the pieces of dead bone here that become separated from healthy bone due to infection or necrosis, creating a persistent source of infection. And then involucrum is the new layer of bone that forms around the sequestrum as the body tries to isolate that infection. Let me go back here. So optimal management of osteomyelitis, and I cover that in these two slides, especially in complex cases like this, it kind of involves a multidisciplinary approach. So we need sometimes microvascular involved, and if it's a really bad case, we can use the help of plastics too. If caught early, better, of course. Typically, the regimen involves 2 weeks of IV antibiotics, followed by 4 weeks of oral. In chronic osteo, antibiotics alone are insufficient. We are hoping that we can take another x-ray and we can follow up and see how his wound is doing in about 10 days. But usually surgical intervention is needed where we debride the bone, and after surgery, we would have to target antibiotic therapy. And right here is kind of a good visual for when to go for a medical conservative route versus surgical. I think this is a challenge because ideally we would amputate this patient right away and, you know, after that do IV antibiotics. But giving his social history on this medical side could be better. So patient is definitely too unstable for surgery. He definitely has poor postoperative mechanics. So for example, he is doing a lot of walking and he's working. But definitely surgical just poses way too many threats for him. So I have lengthy articles here below. Overall, managing dead space left after the debridement of a surgery like that is critical to prevent infection. Options include bone grafting too, using like an antibiotic eluting materials that fill the void. I know there's a lot of companies that, you know, it's kind of like a powder that fills the bone and that already has the antibiotic in it and helps manage a local infection, which is what we think that patient has. And we're hoping that is what it is. In severe cases, reconstructive techniques like bone transport may be necessary to restore the function and the structure of the affected bone. Additionally, like I said, vascular support is vital to ensure adequate blood flow to the affected area, especially in cases where peripheral vascular disease complicates healing, or in this case, diabetes. This may require maybe an angioplasty if we figure out that he also has vascular compromise, because we want to improve the blood supply before attempting further surgical management. Any implanted hardware, if you were to have any from before, for example, if this were to spread to the left, where he's had about 3 surgeries for his Charcot, that would need to have immediate removal. So all in all, this case highlights the complexities involved in diagnosing and managing osteomyelitis, particularly in patients with chronic health issues, and it challenges social circumstances the most. Because we can see osteo and we say, okay, we're going to take it off, but the postoperative can really make the patient worse than how they were when they came into your office the first time. So successful treatment requires a coordinated effort between medical specialties and tailored patient care strategies. These are my references for my articles. And thank you for your time. Let me know if you have any questions.